So really, the purpose of this evening is to give you an update on cancer screening guidelines. Several cancer screenings did have updated guidelines in the past year, so we want to make sure you all know who should be getting screened, how often you should be getting screened, the details of screening for each of the cancers. And we've also seen in the past year during the pandemic that folks really aren't getting screened as much as we'd really like to be seeing. So we're really also trying to encourage everyone to kind of get back on track with screening and begin talking with your primary care providers again about screening. So the plan for this evening, here's a little outline for this evening. We do have 3 panelists who are joining us, and our first panelist will talk about breast and cervical cancer screening guidelines. Our second panelist will talk about colorectal cancer screening guidelines. Then we'll follow that up with lung cancer screening guidelines, and then finish the evening with a Q&A with everyone. So like I said, feel free to throw your questions in the chat throughout the night and we'll get to them, but you can also come off mute during the Q&A at the end. All right, so without further ado, let's go ahead and get started with breast cancer screening. I'd like to introduce Dr. Morrow, Kathy Morrow. She is an associate professor at Dartmouth-Hitchcock Medical Center and the Geisel School of Medicine at Dartmouth, and she's also a practicing physician. She actually teaches and practices at our Heater Road facility and really has expertise in shared decision-making between patients and providers. And at the end of the day, Kathy is really passionate about prevention and was really excited to join us all tonight to talk about breast cancer screening and colorectal cancer screening, which are 2 topics she cares a lot about. So Kathy, I'll go ahead and pass it to you.
Thank you, Jenna. I appreciate the opportunity to talk to you all this evening, and I want to reinforce Jenna's instruction early on to just write. I suspect there are going to be a lot of questions, and we all have a fair amount of material to breeze through, but we really look forward to your questions. So I encourage you to type them into your chat as we go along, and we'll be sure to try hard to get to all of them. Next slide, please. So breast cancer, just a quick run through of some numbers that are important. As most of us know, it's the most common cancer in women after skin cancer. So really it's the second most common cancer in women. About 280,000 new cases. In 2021, about 15% of all cancer cases and about 7% of cancer deaths. Second leading cause of cancer death, but a really good survival rate. We've had ongoing improvement in survival in breast cancer, and the current five-year survival rate is 90%. Interestingly, about breast cancer, the incidence of it nationally is very stable. So in 1992, there were about 130 women diagnosed per every 100,000 women. And in 2018, the number is almost exactly the same. So in terms of frequency in the population, it's quite stable. As I mentioned, survival continues to improve, but the death rate, and there are the numbers, excuse me, for the death rate, which shows that back in 92, 31 women died for every 100,000. And in 2018, we're down to just under 20 per 100,000. So good news in that sense. So who's at risk? Well, as most of us know, there are risks for cancers that you can't change. And then there are risks that you can change. I'm going to start on the ones you cannot change. And that's a positive family history, particularly in first-degree relatives, and particularly if there were first-degree relatives in your family who were under the age of 50 at diagnosis. Important to remember that first-degree relatives in the case of breast cancer generally means mother, sisters, aunts. It's also true that if you have a lot of family members at further away, such as grandparents, And there are a number of them with breast cancer that increases your risk. Increasing age, a risk we can't avoid, but it's true that the older women get, the more likely the risk of breast cancer, and long-term and increased estrogen exposure. Radiation exposure can increase your risk, and DES exposure in utero. I can talk more about that later if there are questions. And then there's what many of us know something about, which are called the BRCA1 and 2, genes 1 and 2, harmful mutations of breast cancer susceptibility, more prevalent in certain ethnic groups, present overall in about 1 in 3 to 500 women. But this is important. Lots of people think, well, it's just those women in that genetic group, but it's really not true. BRCA breast cancers account for only about 10% of breast cancers and about 15% of ovarian. Next slide, please. And then there are the risks that you can change. And these are my favorite ones to talk about because these are the ones we primary care doctors like to really try to help our patients focus on when they're young and healthy before they're facing this diagnosis. So being overweight or obese increases your risk of breast cancer. Your level of physical activity, so being physically active, exercising daily, 3 to 5 times a week, decreases the risk of breast cancer. Prolonged hormone replacement therapy, which is again that estrogen exposure issue, raises your risk. A later pregnancy, so first pregnancy after age 30 and not breastfeeding, both can add to your risk. And then alcohol consumption. Being a heavy user of alcohol also increases. Next slide, please. So how do we screen? I think everybody knows that we screen with mammography. Self breast exams and clinical breast exams, things that we used to do a lot of recommendation about, have been proven in terms of data to not be effective as screening methods. But I want to emphasize, and the reason I put a star there is to say very clearly that though there is not data that proves they are effective as screening methods, this does not mean that they're not valuable or useful. And I'm happy to talk more about that later. Breast screening, mammography screening rather, continues to be controversial in terms of the frequency. Expert panel recommendations continue to change. And I've given you a very brief little summary there. The American College of Radiology has the most conservative recommendations, which state that one should begin at age 40 and occur annually. The US Preventive Services Task Force is the most liberal of the recommenders, and they recommend every 2 years, starting at age 50. And then the American College of Obstetricians and Gynecologists and the American Cancer Society, who are 2 other major recommending bodies around the issue of breast cancer, have recommendations in between those 2. And again, we can discuss that more later if there are questions. Next slide, please. So what's the solution to this dilemma? Well, and here you'll hear my primary care doctor self say very loud and clear that I really believe, and all the bodies that make recommendations also believe, that a shared decision-making conversation between you and your primary care provider that really looks at your individual level, personal risk factors, and shares all the information and knowledge that you need about the benefits and potential harms of screening mammography is the solution to the dilemma, if you call it that, of the controversy about how frequently we should screen for breast cancer. Next slide. There's a balance between benefits and harms, which really depends on your individual risks. And all these societies and individual providers and patients all value the benefits and harms differently. And that's sort of the heart of the controversy. And that's why shared decision-making on an individual level is so important to solving this problem. Next slide. This is an example of a risk assessment, shared decision-making tool that we use in the clinical space to help women think through the benefits and risks. And I'm not going to go over this in any detail today, but it gives you a pictorial sense of what are the benefits and risks depending on which frequency you might be interested in thinking about for your own breast cancer screening. Next slide. So, summary, all of us, our jobs are to identify women at increased risk due to personal and family histories, make sure that those women who are at high risk get to genetic counseling within or not a comprehensive breast center, so that those women get in particular evaluation as is appropriate to their risk factors, get shared decision-making starting at age 40 for the average risk women, and make sure that women between the ages of 50 and 75 are screened at least every 2 years. Those are the basics that pretty much everybody agrees on. Next slide, please. Okay, I'm going to move on to cervical cancer screening, which is a little more straightforward. Cervical cancer, the great news is slowly but surely heading for elimination, at least in the US. There have been 15,000 new cases in 2021. It's a very small percentage of all cancers now, less than 1%. The incidence of it has declined by 50% between 1975 and 2010. The backbone of screening is pap smear and HPV typing. And the future really looks positive for elimination of cervical cancer thanks to HPV immunization. Next slide. So all cervical cancer is caused by human papillomavirus, known as HPV, virtually all. Risks are directly related to your level of exposure, and there's greater than 100 types of HPV. This can get confusing, but you don't have to know about all those types because there are only about 4 to 6 that are really related to cervical cancer. The majority of people are exposed over a lifetime to the human papillomavirus, and the majority of us clear it without any symptoms or even knowledge that we were ever exposed. Other risks that are distinct are smoking, HIV positivity, a history of multiple sexual partners, and use of birth control pills for prolonged years can all increase a woman's risk for cervical cancer. Next slide. So there are some very straightforward recommendations. The American Cancer Society recently updated their recommendations, the US Preventive Services Task Force, and those two bodies are pretty much those that people pay attention to in terms of cervical screening. And there's not a lot of discrepancy between these recommendations. The cornerstone is a PAP and an HPV test, which are done at the same time, at the same visit, every 5 years, once you've reached age 30, and somewhere between every 3 or 5 years, depending on the recommender, younger than that. We do not screen young women anymore under the age of 21, even if they are sexually active. And it's because it's become clear that though you can be exposed and show positivity for HPV, the vast majority of us clear the virus on our own. We stop screening women at age 65 or older if they've had a history of normal tests and are not at high risk. Next slide. And this is just a summary, again, of the US Preventive Services Task Force, which we can keep go ahead and skip past. Thank you. So I want to emphasize that the real future and excitement about eliminating cervical cancer is rooted in HPV immunization, which has been around now for more than 10, 15 plus years. The CDC recommends routine vaccination of all but generally we start talking to parents and kids between 11 and 12. 2 doses when given between the ages of 9 and 14, 3 doses if given older. It's been approved for up to age 26, and most states cover the immunization when it's given to preteens. There is a lot of variation between how states pay for immunization for older people, those between 18 and 26. So it's valuable to know in your state when the coverage occurs. And as I mentioned, there is a real promise within the world of cervical cancer for the elimination of cervical cancer because of that vaccine. And next slide, I think that's probably it. Yes.
Awesome. Thank you, Kathy. So like we mentioned, I'm sure you have plenty of questions about cervical cancer screening or about breast cancer screening, and feel free to drop those in the chat. We're definitely going to have time to address them at the end of the panel discussion. But I do want to move us to talking about colorectal cancer screening. And with that, I would like to introduce Dr. Calderwood. Audrey Calderwood is an associate professor of medicine at Dartmouth-Hitchcock Medical Center and at the Dartmouth Institute. She directs the Comprehensive GI Center and the GI Risk and Prevention Clinic at Dartmouth-Hitchcock. She's also really passionate about improving colorectal cancer care and colorectal cancer screening. And in fact, she has a number of research grants to do just that. And in fact, received a very prestigious grant just 2 days ago to continue this work. So Audrey, feel free to take it away.
Thank you so much, Jenna, for organizing this wonderful event, and to the American Cancer Society for your partnership. I'm honored to join my co-speakers and really thank the audience for tuning in tonight. Next slide, please. So what I hope to cover in the next 10 minutes is an overview of colorectal cancer, explain a little bit about the rationale for screening and why it's effective for prevention of colorectal cancer, and then spend most of the time talking about getting screened, particularly who should be screened, how to be screened, because there are several options, and how often. Next slide, please. So as you can see from this headline, colorectal cancer is the second most common cause of cancer death combined between men and women in the US. So that means, every year that's about 27,000 or so deaths in US men and 24,000 deaths in US women. So this is a big deal. Can you hit forward, Jenna? And when we think about the lifetime risk of getting cancer, so shifting away from cancer death, but just getting colorectal cancer, it's about 4% for both men and women. So about 1 in 23 for men and 1 in 25 for women. So fairly common. I think most of us probably know someone or had a family member, or at least know people in the media recently, right? And in the past who've had colorectal cancer. So I'd like to just take a little time to explain the pathway of how colorectal cancer usually starts, because this slow timeline will really highlight why screening is possible and effective. So on the left is a picture of the normal colon as seen through colonoscopy. And then you see it can over time develop a small adenoma, or as people call a polyp. Over time, if left alone, that adenoma can grow and grow. Not all of them will, but some will grow and become larger. And when they become larger, there's a chance for some of those cells to change and become more aggressive. And that's how colorectal cancer, shown on the right, can form. Now, we know this process takes a long time, anywhere from 9 to some estimate up to 23 years. So this long time frame really provides an opportunity to help identify these polyps and remove them, and or identify cancer early before symptoms start. So you might be asking yourself, what are some symptoms? So typical symptoms depend on the location of where the cancer forms, but includes anemia or a low blood count, bleeding, so blood in your stool, or even change in bowel habits. So here, as you can see, are the US Preventative Services Task Force guidelines, and these were updated just this year. And so I'd like to take you through it. So the first box at the top in green shows that it recommends screening for adults aged 50 to 75 for prevention of colorectal cancer. And that received a grade A recommendation, which, Jen, if you just hit forward, equates to substantial net benefits, meaning the benefits far outweigh the harms. And this is uniformly for people aged 50 to 75. Now, if we go to the next green box, that's really what was in the headlines this year, and what was new in these 2021 guidelines is that this organization recommended screening also for people 45 to 49 who were not previously recommended. Now, why is this? Well, the risk of developing colorectal cancer in this 45 to 49-year-old age group is about 20 out of 100,000 people. That's still a lot lower than in the typical group of 50 to 75, which is about 50 new cases per 100,000. So that's about half. But what's interesting is when we look at this cohort, so people born in the ages where they might be 45 now, there's an increasing risk of colorectal cancer in these birth cohorts compared to people in their 50s and older. And that could be due to lifestyle factors, rising obesity, change in diet. So that's why there's modeling studies that show that starting screening at 45 likely increases life expectancy in this age group and decreases colorectal cancer cases and death. Lastly, I'll just quickly highlight in the yellow box here that for people 76 to 85, there's a soft recommendation about colorectal cancer screening. It's up here for you to read, but in essence, the take-home message is that this should be an individualized decision between you and your doctor if you're in these age groups, because the benefit is really uncertain. There's a possibility of small net benefit, but there are also harms, and this has to be weighed in the context of somebody's overall health, whether or not they've been screened before, and also their preferences, which are really important. I'll just highlight here that there are some high-risk populations. If you have a family history of colorectal cancer, particularly if you have a first-degree relative, as Kathy was alluding to, with cancer before age 60, that's considered high risk. If you have a known genetic cancer syndrome, or certain medical conditions can predispose you to a higher risk of colorectal cancer, inflammatory bowel disease, and then rare conditions like cystic fibrosis and kidney transplant. So let's take a little bit of time to talk about 3 different types of screening. I won't cover all the options that are available, but I'll highlight those that are used frequently in this country, in particular this area. I'm not going to talk about flexible sigmoidoscopy or CT colonography, which is a special CT scan that can be done. But I'd like to spend some time talking about stool-based tests. So here you see something called FIT, which stands for fecal immunochemical testing. This is done with a single stool sample, and the test is performed in the convenience of your own home. And so the diagram on the left kind of depicts in cartoon what you would do, but basically the kit comes with a piece of paper, you lay it gently in the toilet bowl, you have your poop, and then you take this little probe and you kind of dip it in that stool, and then you put the probe in its cassette and you mail it off in this envelope that's provided, and then you're done. The paper, the poop just flushes away. So there's a lot of benefits to the convenience of it. For example, right, you don't need to clean out your bowel, you don't need to be sedated or have transportation to go anywhere, but it does require being repeated every year if it's normal, because the test improves in its ability to detect larger polyps cancer if it's repeated every year. Next slide, Jenna. Another form of stool-based testing is called stool DNA. Many of you may have heard radio or TV ads from this by its maker called Colorectal. Again, this is a test that's performed at home, so similar advantages to fit in the lack of needing a bowel prep or sedation or transportation. Here on the left, you'll see that the setup's a little bit different, but the same concept. So in the box you receive in the mail from the company, you'll get like a little container that you put in the toilet, and then you're collecting a whole stool. So instead of dipping a probe in the stool, you're collecting the whole thing, you're covering it up, and you're putting a little like solution in it, and you're mailing that whole thing back to the company. So for some people, there's a little bit more of an ick factor with this, just dealing with like the stool itself. So that's something to consider. The potential benefit is that it does have a little bit higher detection rate for bigger polyps compared to FIT testing. And because of that, the test may be able to be spaced out to up to 3 years. That's not a hard and fast rule. The company says every 1 to 3 years, but that is what that US Preventative Services Task Force recommends if you choose to have stool DNA testing. Now, colonoscopy, many of you are probably familiar with this. Some of you have probably had them, or at least had a family member who have had one. But the big thing with colonoscopy is that you need to drink a solution to clean out the bowel so that when we go in to look, we can see and find little polyps before they're big and remove them. Most people in the US will be sedated for this. Some people choose not to and do okay, but most people prefer to have it with sedation. So you can't drive yourself home and you can't go back to your regular work. And therefore you need someone to take you home. So that can be quite inconvenient, especially for people who live alone or are more isolated. It does require less frequent screening if normal, so every 10 years compared to every 1 or 3 years. I would like to spend just a little bit of time on the potential harms with colonoscopy. And that's because every other positive screening test, including the stool-based tests FIT and stool DNA, if abnormal, lead to having a colonoscopy needing to be done. So all of these risks would apply to colonoscopy and then for follow-up of any other abnormal screening test. So if you took 1,000 people, about 15 of them undergoing colonoscopy might have heart or lung troubles due to the sedation. Usually it's temporary. Usually there's no long-term consequences. About less than 5 to 10 might have any form of bleeding, serious bleeding requiring a transfusion or coming into the hospital. And that's typically if people are on blood thinners or large polyps are taken out. And less than colon, and some of these people might require surgery to fix it. So while these complications are rare, they are known to happen and need to be considered, especially as you weigh the pros and cons of each approach. We do know that these risks increase with age and certain medical conditions. So in summary, I know that was a whirlwind tour, but I hope I was able to convey the rationale for colorectal cancer screening, highlight recent changes in the guidelines, lowering the screening age to 45, and discuss several options about screening with their unique characteristics. Hopefully that will enable you to make an informed choice or help educate your family and community on the importance of colon cancer screening. Now, some may find colon cancer screening in particular overwhelming because of the variety of options. But I think it's important to remember what Dr. Winauer here said so eloquently is that all of us need to embrace and celebrate every successful screen. The best screen is the one that you do. So thank you, Jenna, and I'll turn it back to you.
Perfect. Thank you, Audrey. That was so great. And so we'll move it toward lung cancer screening now, but I do just want to remind you that you're welcome to drop questions in the chat or after the next session from Rian Hasson, we will have time for questions as well. So feel free to wait, or you can drop them in the chat now. So I do want to introduce Rian Hasson, who is a thoracic surgeon at Dartmouth-Hitchcock Medical Center, and she's also an assistant professor of surgery. She actually joined Dartmouth-Hitchcock in August of 2018 and co-directs our lung cancer screening program. Ryan's current research work focuses on identifying and addressing disparities in lung cancer screening, and she's a huge advocate for getting screened for lung cancer. So I'm going to go ahead and pass it over to Rian. Thanks, Rian.
Hello. Thank you, everybody, for joining. I hope that over these next couple of minutes, I'll be able to give you a little bit about the history of lung cancer screening, give you some reasons why you should consider getting screened, give you information that you can tell your friends or family members if they fit the criteria for screening, and then also just have more information in general about screening and fit in with these other topics here so that you can live healthier lives. So with that, we'll go ahead and start. So lung cancer, as many of you may not know, is actually the #1 cancer killer. And so many people die from this yearly. And one of the problems with it is that it's often diagnosed late stage, meaning either stage 3 or stage 4. Because it usually doesn't have any symptoms until that time. So there's been many different efforts over the years to try to figure out what's the best screening mechanism. And in 2011, there was a huge trial. It's called the National Lung Screening Trial, which included over 50,000 patients. And they looked at whether or not there was a benefit to screening individuals that had a smoking history with either a chest X-ray or a low-dose chest CT. And basically, that chest CT, it's a study that takes about 1 minute to finish. The whole process takes about 15 to 20 minutes because you need to come in and check in. But they put you onto a table, and then that table puts you into a donut that will screen you. And it screens just your chest area, basically from the top of your lungs all the way down to the bottom of your lungs. And it looks to see if there's any abnormalities, such as nodules or tumors or anything else that's abnormal in your lungs there. They did this study on this number of patients and reported a 20% lung-specific mortality reduction, meaning that 20% of the individuals were saved solely because there was a lung cancer diagnosis or lung type of disease process identified that ended up saving their lives. In general, 6.7% had an overall mortality reduction, meaning that they found something on this study, whether it was with their heart, somewhere else in your chest, somewhere in your lower neck, that actually saved their lives. And so I should point out that with lung cancer screening, it is the only screening mechanism that has both a lung-specific mortality reduction, but also an overall mortality reduction. And so again, this wasn't a study of individuals that had a history of smoking. So as a result of these findings, many organizations published guidelines recommending annual screening for high-risk patients in 2013. And Alice just asked a question, and it's very important. I'll get into that into the next slide, but yes, it is fully covered by your insurance. We'll get a little bit more into the specifics a little bit later on, but yes, it's considered preventative care. So just like when you go to the dentist and you get a cleaning and it's covered, the low-dose CT is covered. Okay, go on to next slide. So the initial guidelines were here, okay? And again, this was back in 2011, and it was individuals 55 through 77 years old, those that were still currently smokers or had quit within the last 15 years. And the tricky part is the pack year history, but once we break it down, hopefully it's not as tricky. But it's those with what they consider a 30 pack year history. So what that means is smoking a pack per day or the equivalent for 30 years. So it could be 1 pack per day for 30 years. It could be 2 packs per day for 15 years. It could be half a pack per day for 60 years. Any of those combinations to get you to that 30 pack year history were what those original guidelines were. There was a couple of other criteria, given that we're dealing with patients that would be more mature. Your life expectancy was expected to be more than 3 years. You can't have any other type of cancer because you're going through surveillance with that, and that may affect the results on this. You need to be willing to undergo treatment if we do find something on the CT, and I'll talk about that in a little bit. And then you also just need to have no other major comorbidities, meaning other health problems that would prevent treatment. So if you weren't able to undergo treatment, then we don't recommend undergoing screening. Next slide. And so much like breast cancer screening with mammographies, they came up with a scoring mechanism. And I won't go into the details of this, but a lot of this came about because they needed to come up with a standardized way to read these chest CTs and make it standard across the board of what does it mean when we see a 5 mm lung nodule versus a 2 cm lung nodule versus a 10 cm lung nodule. Or what does it mean with the different types of nodules? Or what if we see another abnormality? And so they came up with something called lung rads, and much like most people will know about BI-RADS for mammography, there's lung rads for lung cancer screening. And again, the purpose of this was to kind of level the playing field across the board and give our radiologists a standardized method to read each CT scan and then come up with a scoring system for it so that providers across the nation would know what to do with these results. The first two, I'll go over them very quickly. The first two just mean that either you had no findings or we found findings, but they're benign in nature. If you're a lung RADS 3, that means that we found something and that we should probably get another CT scan in about 3 months, just to make sure, 3 to 6 months, just to make sure that everything looks okay, or that this is either going away or it's not getting any bigger. And then lung RADS 4, there's 3 different categories, 4A, 4B, and 4X, which basically categorizes that, hey, this is pretty suspicious. We either think you need to come back in 3 months or you need a referral to a thoracic surgeon, et cetera, in order to get this worked up a bit. So again, this was here to standardize the screening process. Next slide. Unfortunately, when this first came out back in 2011, between 2011 and 2014, there was some misrepresentation of the false positive rates. And it actually made it to the New England Journal, which is one of the most prestigious journals that you can publish in. And the false positive rate was actually listed at 97.5%. So naturally, providers were, said, pump the brakes, we need to hold on this. And unfortunately, a lot of people missed out on that screening because that false positive number was reported incorrectly. It was a VA study that this happened in, and the true false positive rate at that time, as you can see in the chart here, was actually only 27%. Since that time, it's gotten much better. And so when we looked at the database back in 2018, we were down to 15%. And then here at Dartmouth-Hitchcock, we've been at about 5% for the last 5 years almost. So that means that out of 100 people that get screened, only 5 may have a false positive rate. But of those 100 people, lives will be saved, not only from lung cancer, but from finding other diseases. Okay, so go ahead and next slide. So now, fast forward, this initially came out about 10 years ago to the date. It's 2021, and this came out in 2011. We've gotten much more data on many different populations. We know that those guidelines that they initially created were great, but it also leaves out some folks that are at high risk for lung cancer and that we're just missing with the screening criteria. So the United States Preventative Services Task Force just recently came out with current guidelines, and that includes 50 to 80 years old. Okay, so they've dropped it now from 55 to 50. It's still those that currently smoke or have quit within the last 15 years, but it's now those that have a 20-pack-year smoking history instead of 30-pack-year smoking history. They realize that in certain populations, specifically Black and African American populations, those that of lower socioeconomic status, those that have less access to care, patients were starting to smoke at earlier ages. They weren't quite reaching the 30-pack years, but because of their history of smoking earlier, they were getting lung cancer earlier. So they have these new guidelines. Now, to go back to Alice's question, currently, Medicare and private insurance companies pay for the screening if you meet that original criteria. Medicare is up to review these guidelines and should be going over those by the end of the year, but they are not yet covered by all insurance companies. So it's important for you to ask your insurance company, hey, do you cover this screen for me? Because otherwise you would need to pay out of pocket for it until you reach that age of 55, but most likely these will be approved by insurance companies within the next year to two. Okay, next slide. So where we are today, you know, it's unfortunate because this is such a great screening tool, but it's a large number of patients still don't participate. It's estimated that only about 5% of eligible patients participate compared to about 70% with breast and colorectal screening. There's a lot of reasons for that. I think the number one reason is people don't know that it exists. I see so many patients that come to my clinic and don't know about it and don't know to ask for it. Whereas things like colonoscopies and mammograms are pretty commonplace in our society, and most people either know about them and maybe even dread them, but they go and do them. Unfortunately, we don't have that same benefit with lung cancer screening. There's a lot of patient roadblocks in terms of access, as I was talking about before. There's provider roadblocks because there is a shared decision-making conversation that needs to take place before an order can be placed for you to have this. And it is very hard, as you can imagine, when you go to see your PCP and they're talking to you about all of these different screenings, to talk to you about other things, specifically lung cancer screening. Here at Dartmouth-Hitchcock, we've tried to assist our primary care providers by creating the pulmonary nodule clinic, which can have the shared decision-making conversations with you and talk to you about specifically the risks, the benefits, okay, and why you should consider participating in lung cancer screening. So we're hoping to overcome some of these barriers. But we really are trying to do our best to get more engagement from the population. So I think I have one more slide. So what can you do and how can you help yourselves in your community? Well, I think number one, learn more about lung cancer screening. Hopefully you got some questions answered about what it is and who qualifies for it and how it's paid for. The one thing I will say about paying for it is that, say, for example, they find something on your lung cancer screening CT, if you were, or you fit in that lung rags 3 category where they recommend another screen, that's when your insurance would start to kick in and it would start to pay for these things. And you would start to see the normal deductibles and copays that you would usually do, just like with a mammogram or a colonoscopy, if they found something on that too as well. So that's important to remember. But again, the benefit that you would gain from it and possibly diagnosing lung cancer at an early stage, we really feel is worth it. And so it's definitely something to consider. 2, I would ask you to ask your primary care provider if you have more questions about it. Be an advocate for yourselves, and it's okay to ask about this, or ask your friends or family if you have anybody that you know in the medical field to help give you more information. You can also go to the United States Preventative Services Task Force website to see the guidelines and see more criteria about it. Encourage your friends and family members to speak to their providers. If you know anyone that has a smoking history, whether they're a current smoker or if they have quit within the last 15 years, they may qualify. So tell them to ask their providers about this. And then the last thing is that if you do still currently smoke, it's never too late to quit. We have a great smoking cessation resource center here that is here to help you with your needs and help you to try to stop this habit, but more importantly, get screened and look out for things that may have affected your health or may be affecting your health. It's important to note that not everybody that has lung cancer smokes. Okay, about 20% of the population doesn't, but we know that 80% do have a risk factor of that. And so if you do, I encourage you to go and get screened. And it's a yearly process, but it's a process that could save your life. So I thank you for your time and attention. Thanks, Jenna, so much for inviting me on this panel and for being able to speak with all these esteemed speakers, Dr. Calderwood and Dr. Morrow. And we invite your questions, so please ask.
Perfect. Thank you, Ryan. That was really wonderful. So I'm going to stop sharing the slides so that we can have an opportunity to really ask questions of our panelists. And I do want to start actually with Kathy. We had a question for you in the chat early in the evening about genetic testing and how someone should go about exploring whether genetic testing is right for them for breast cancer risk. Can you speak to that?
Sure. Thanks for the question. Most women know, or rather are alerted to the need for potential BRCA testing based on their family history. And it is their family history. There are family histories of breast cancer, and then there are women also from families with combined breast and ovarian cancer histories. So the majority of women who undergo BRCA testing will be women who come to us with the information that, gee, I have had several relatives die of breast cancer. Often we don't know a lot about the details of those breast cancers, particularly if they were in earlier generations. But if you have a cluster of those family members or a number of them, those are the women who we refer for genetic testing or to comprehensive breast centers where they can do very thoughtful evaluations about an individual woman's risk and ascertain if she should undergo the genetic testing or not.
Perfect. Thanks, Kathy. I do now have a question actually for Ryan. Ryan, we had a question in the chat about whether secondhand smoke exposure can substitute at all for those 20-pack year history criteria in lung cancer screening. Can you speak to that a little bit?
I can. So unfortunately, right now, it doesn't sub in for you meeting the criteria. It's based directly on what you have smoked yourself. They're currently looking at that though, because we do see a lot of patients that have had exposures like that or grew up in households like that or have partners or other family members within their house that have been smoking for quite some time and they have an exposure risk. The best advice that I give to patients is that if you have that within your history, be mindful of your symptoms if you have any new symptoms whatsoever. So if you have a new cold that's not going away, talk to your provider about it. You know, if you are diagnosed with something and you get a course of antibiotics and those antibiotics don't work and you're not feeling better, go back to your provider and tell them about that. But just be vigilant about your health, because unfortunately you can't get screened, but you know your body's the best, better than any of us providers will ever know them. And so if you have any things that just don't feel right, that just aren't going away, that is disrupting your life, definitely talk to your primary care provider about that. I'm hopeful that within the future, just like they changed the guidelines, even though it took 10 years, that they will look at this too, especially with the advent of vaping and hookah and the legalization of marijuana. There's so many other things that could contribute to this. It will take a while for us to do long-term studies and get the clinical data to back that up. I mean, if that's one of the strengths with the National Lung Screening Trial, is that we had the many years of tobacco data to back that screening up and base it solely on science, so that we're giving you scientifically based recommendations on large populations of people. But I'm hopeful that we will make advancements towards that era so that we can include other high-risk patients and not just those that have a tobacco history.
Perfect. Thanks, Ryan. That's super helpful. I do actually also have a question for Audrey about colorectal cancer screening. Wondering about questions that patients should be prepared to talk to their providers about.
Thanks for that question, Jenna. Yeah, I think one important thing is to have a conversation, about your preferences. So thinking more broadly, not just about colon cancer screening, but, how worried are you? Are you someone that worries? Are you someone who thinks I'm probably not going to get it? How risk averse are you? How inconvenient are certain tests to you? Do you like to be one and done, just get it all over with? Then maybe colonoscopy is good. If you have a polyp, they can remove it. You might be good for 5 or 10 years. You don't have to think about it. Are you someone who is busy, can't take a day off? Work is a big obligation. You don't want to do the prep. A stool-based test once a year or every 3 years might be something that appeals to you. So working with your doctor to work through your preferences, and they likely may be able to help you if you've had a long-standing relationship with your primary care doctor in thinking about how you would think about a positive test with a stool-based test. In all likelihood, a positive stool-based test does not mean you have anything serious, but it does mean you need a colonoscopy. So, for example, would you be at home worrying in that time between that positive test and the colonoscopy? And if you're someone who's really anxious about that, maybe you'd rather have a different type of test. So I think thinking about your preferences is really important. Other patients have questions about lifestyle habits and how they can reduce their risk. We do know that certain factors are associated. So obesity, heavy smoking, just like in some of the other cancers we're talking about here. Diets high in red meat, so more than 2 times a week with red meat. Low fiber diets. So those are some of the things that have been associated. They've also looked at other supplements to see if they can prevent cancer. And a lot of that work actually was done at Dartmouth with something called the polyp prevention trial. So they've looked at calcium, vitamin D, folate, beta carotene, and none of them have really panned out as something that people should take to prevent colon cancer. But we do know that these other healthy lifestyle habits may reduce your risk.
Audrey. I think we have time for 2 more questions. So first, I'm going to pivot back over to Kathy. Kathy, we've had a few questions in the chat about risks or potential harms of mammograms, and I'm wondering if you can talk to that a little bit.
Thanks for those questions. And I'm really glad to have a moment to address that, because when we talk about risks of mammography, it's really important to understand that the test itself has no inherent risks. Unlike, for example, colonoscopy, as Dr. Calderwood explained really thoroughly what some of the risks of the actual procedure are, other than the discomfort of mammography, and all of us women love to complain about our mammograms and how uncomfortable they are, because they are. They flatten your breasts very firmly in the machines in order to get good pictures, and it hurts. So other than those, the discomfort, there are no risks to the procedure itself. So when we talk about risks and benefits, or harms rather, what we're really talking about is the dilemma of false positives. And that is an idea that means your screen looks like it might have something wrong on it, that there is a spot or a area of vague density, or there are all kinds of things on a mammogram that can look abnormal that actually are not. And that's the challenge of the technology. And so many, many women, and I'm going to guess just sitting in this room tonight, there's more than one of us who've had what's known as a callback. And a callback is that you get a call from radiology saying, we've seen something on your mammogram, and we need you to come back and get extra spot or special films. And it's happened to me. It's a very nerve-wracking experience. It immediately raises fears about breast cancer, of course. And in some cases, a subset of those cases, women will undergo biopsies and procedures that all do actually involve risks to the patient that turn out to be nothing. So the technology is not perfect. And that is true of all technology. But in mammography, the dilemma is the technology is less than perfect. And there is a moderately high rate of this false positive mammography that requires further evaluation, workup, sometimes just extra films, but sometimes biopsies and invasive procedures.
Thanks, Kathy. And for our final question, it'll go to Audrey about colorectal cancer screening, or rather colorectal cancer risk, really. Someone asked about having a polyp and whether that's essentially a sign you'll get cancer or what really the risk is of developing cancer.
Yeah, really great question. I think people wonder about that a lot. So the short answer is no. Having a polyp is not a sign you'll get cancer in any way. So we talked about how the lifetime risk on average in the US is about 4%, but about 40 to 50% of people of screening age will be found to have a polyp. And even beyond the types of polyps we talked about, the adenomas that we think may increase risk for cancer slightly, there's other types of polyps that we can find that really don't increase your risk for cancer. So because to the naked eye, we can't tell which polyps are destined to become cancer if left alone for the next 10 years. And technology that we've tried for visualization isn't as good either. We take out all polyps that we see. And because we think making polyps means you might be a little bit higher risk than the average population, we have people come back for colonoscopy sooner than the 10 years, sometimes 3 years, 5 years, 7 years. And actually for that, the years have been extended. We used to basically have everybody come back at 3 years. Then it moved to 5. Now we're saying 7 to 10 is okay. So I think people are realizing these small little polyps that so many of us have really don't increase your risk of cancer, and you can still come back at 10 years. So I think that's a great question, and I'm happy you asked for clarification.
Perfect. Thank you. Well, I want to thank you all for joining us tonight. Really hope you got something out of this, learned something new, maybe even inspired to get screened or talk with your provider about screening, or maybe a family member. I also want to thank Drs. Hasson, Calderwood, and Morrow for being part of this program. And again, thank the American Cancer Society for co-sponsoring this. So with that, I hope you all have a lovely evening, and thank you all so much.